Existing in the middle of the lush and prosperous Sundanese area, which is rich of various culture, and natural magnificence. Becoming milestone in educating the nation, building persons to be society servants and nation founders. Universitas Pajajaran, or UNPAD, was born due to the initiation of West Java leaders and government support to establish a higher education institution with various disciplines. Launched by President Sukarno on September 11, 1957, today, UNPAD has a large number of institutional achievements. Such as status improvement as the incorporated higher education with A accreditation. This achievement is in line with the commitment of all policymakers in order to accomplish the vision and mission of UNPAD to be excellent university in conducting a world-class education that is able to support the nation's competitiveness through a quality learning process and innovative research. The representative learning facilities and strategic campus in the center of Bandung City, Bandung Regency, and higher education zone in Jatinangor, Sumedang make UNPAD as an excellent university in conducting education, research, and community services. Through its best programs enabling to fulfill the needs of society. Nowadays, UNPAD has 16 faculties and 1 postgraduate school, totally consisting of 152 study programs. Faculty of Law, Faculty of Economics and Business, Faculty of Medicine, Faculty of Mathematics and Natural Science, Faculty of Agriculture, Faculty of Dentistry, Faculty of Social and Political Sciences, Faculty of Arts, Faculty of Psychology, Faculty of Animal Husbandry, Faculty of Communication, Faculty of Nursing, Faculty of Fishery and Marine, Faculty of Agricultural Industry Engineering, Faculty of Pharmacy, Faculty of Geological Engineering, Postgraduate School. Realizing the importance of learning process, curriculum and learning method are continuously developed in order to adjust the dynamics of stakeholders' needs. Nowadays, UNPAD has used student-centered learning method. That is, learning method focuses on students as the base to actively involve in developing knowledge attitude and behavior with competence-based curriculum. Supported with professional faculty members and staffs, UNPAD is capable of generating competitive and characterizing graduates. Until now, it has registered 10,000 of students from all over Indonesia and hundreds of international students studying in Universitas Padjadjaran. To optimize the education and learning processes, UNPAD is supported with various representative supporting facilities such as library, Basic Science Service Center, Language Center, e-learning, teaching hospital, and dental hospital. In addition, UNPAD is also equipped with student dormitory, health facility, sport facility, campus transportation, banking, hall, and entrepreneurship facility. Such various facilities are supported with the utilizing of information technology. Besides supporting the academics quality, Universitas Padjadjaran also fully supports the activity of student character building through some student unit. As a part of society, Universitas Padjadjaran absolutely realizes that its function is limited not only in teaching, but also social and cultural aspects. Some social activities, society empowering, and research real benefits for all society. Universitas Padjadjaran, straightening and developing together with society. From West Java, for Indonesia, to the world, through SDGs.
Are you interested in learning about cleft lip and palate with experts from around the world? And you can learn this for free while gaining 3 credits. Come join our online course in collaboration with Faculty of Dentistry Universitas Padjadjaran and SmartTrain.
Greetings from Transcendence 2021, massive open online course in cleft lip and palate, held by the Faculty of Dentistry Universitas Padjadjaran, collaborating with SmartTrain and YPPCBL, has been going on for a few days. My name is Josephinda. I'm a preclinical dental student from the Faculty of Dentistry Universitas Padjadjaran, Indonesia. I see that we came from different countries, so I think it is appropriate to say good morning, good afternoon, and good evening to everyone here. Also, greetings to our expert today, Prof. Puneet Batra from Institute of Dental Studies and Technologies, Madinagar, India. Thank you for being here. It's been an honor, a pleasure, and we really appreciate your presence here. How are you, Professor?
Very well, ma'am. Thank you for the kind introduction.
Thank you very much. Thank you for giving time here and hope you are doing well and stay healthy. And we also have our moderator here, Dr. Lisda Damayanti, prosthodontic specialist as the moderator. She is one of my prosthodontic lecturers in Faculty of Dentistry, Universitas Padjadjaran. She will get you throughout the first and second session of this live discussion. Hello, Dr. Lisda, how are you?
Hello, I'm fine, thank you.
Okay, thank you very much, Doc. And also greetings to all of the participants. Thank you for participating in this course and thank you for attending this live discussion session. So, Professor, today is our second live discussion for this week. In the previous week, we have discussed introduction of CLP, etiology of orofacial cleft and the role of environmental factors, developmental anatomy of CLP, and genetics in cleft. Today, we will discuss about presurgical nasoalveolar molding. This live discussion will be separated into 2 parts. The first session, the professor will be answering the questions that have been filled out by the participants on the MOOC platform. The questions will be presented on the screen. The participants have already watched the lecture video about the related topics, which is presurgical nasoalveolar molding. So they have seen your lecture, including me. So last night I watched your lecture, and I want to appreciate Prof. Puneet, because Prof. Puneet can explain this topic clearly, and I can see what you are trying to explain to us. And even though I think not everyone can make it into this live discussion, but don't worry, I'm sure that all other 300 participants that have registered for our courses have watched your lecture video as well. And then next, in the second session, the participant will have the opportunity to ask the questions directly to the professor through the Zoom chat, or the participants can write down the questions, their name and where they are coming from, and also can unmute their microphone and ask directly to the professor. Now, I would like to give the spotlight to our moderator, Dr. Lisda Damayanti and Prof. Puneet Batra as our speaker. Dr. Lisda, you may start the first session and lead today's live discussion. Thank you so much. Now we are moving on to the first session.
Yes, thank you for the time, committee. Good afternoon, ladies and gentlemen, the participants of this MOOC, Massive Open Online Course Seminar. It is an honor to attend this educational event, the above cleft lip and palate. Before we started, I would like to introduce again Professor Puneet Batra. I'm sorry, Prof, if there is any misspell in your name, from Institute of Dental Studies and Technology, Modinagar, India, as our speaker today. And he will be talking about presurgical nasoalveolar molding for infant with cleft lip and palate. Good afternoon, Professor. How do you do? It's my pleasure to see you. Thank you for giving time to attend this event. And also I would like to introduce myself as moderator for today. My name is Lisda Damayanti. I'm lecturer at Prostodontic Department, Universitas Pajajaran. Okay, where can we start now for discussion, Professor? Okay, let's move on to some question and answer. The committee, please may share the first question. Now, for the first question, is a NIME appliance the same as feeding plate?
NAM appliance.
This is a quite short question, Professor. Please, you may answer the question.
See, for a beginner, he needs to understand that a feeding plate was meant to assist feeding. You know, when you have a cleft of the palate, there is an opening into the nasal cavity. So a feeding plate was initially given to the babies to assist in feeding, to close the palatal gap. But now research says that giving a feeding plate has no role. You know, feeding plate has no role in cleft treatment, because if you are able to learn the proper way of feeding the baby, you will not need a plate. So first of all, you need to understand that feeding plate many years ago used to be thought as an important part of treatment for cleft children. But nowadays, after a lot of systematic reviews and meta-analysis, it has been concluded that a feeding plate has no role in assisting in feeding. The children who were given feeding plates and who were not given feeding plates, they both grew equally well. So, feeding plate has no role. However, NAM appliance also does the job of a feeding plate, because it is a plate which will, close the palatal area. So NAM appliance does the job of a feeding plate as well. But feeding plate per se is not required for cleft treatment. So I want to again reiterate that, okay, but a feeding plate is not required to be given to any cleft baby.
Yes. Thank you, Professor. That's very insightful answer. In our faculty also is doing a specialistic prosthodontic program. Also is treatment for infant with cleft lip and palate using PNAM, combined with nasal stent and tapping or strapping extraoral as a part of maxillofacial prosthetic. This treatment used to call feeding plate. Particularly to improve nutrition for the infant, but now it is called PNAM because the treatment, also the active molding and positioning of the surrounding soft and hard affected by the cleft.
Right.
Yes. Can we move on the next question, Professor?
Yes,
second question. For approximately how many hours per day in NAM applied to be effective?
The NAM appliance should be in the mouth all the time. Try to understand what are you doing. You are trying to bring the tissues together so that the pressure of the tissues coming together are actually doing the molding. We need to understand the principle of NAM. The basic principle of NAM, nasoalveolar molding, is very simple. That just like when we were small, we used to play with plasticine. We used to make molds of plasticine. Similarly, our tissue is moldable. Why is the tissue moldable? Because when the baby is born, the mother's estrogen, comes into the nasal septum of the baby, and it is high in quantity. So what it helps is that it makes the tissue very easily moldable. You can shape it into any shape you want. Now, as the baby grows, by 4 to 4.5 months, the estrogen levels are falling. So, the good time for molding is the early part. But, it should be worn for at least, I would say, 20 hours a day. But if possible, wear it all the time. It helps in feeding. So it can be taken out only for feeding and let it remain in place for most of the time.
Okay. Thank you, Professor. I think it's very clear answer. Now we move on to next question. What is the minimal and maximal period of NAM to get desired result? Maximal period of NAM.
There is nothing like a definition of a minimum or a maximum period. You need to understand that the objectives of NAM can be finished if the baby comes at the first week of birth. So we could finish, if the amount of correction required is less, we could finish the procedure in 4 months. But if the defect is much bigger, sometimes, and there is no cooperation from the baby, the time, from the parents or the baby wearing the appliance, it might take a longer time. Now, studies which have been done on NAM say that I mentioned to you that the mother's estrogen level will become zero, it will come down in the nasal septum by 4.5 months. So if you are doing NAM after the baby's 4.5 months, you are actually not doing molding. You are doing bone bending. So the effectiveness of the NAM goes on reducing as the time increases. So there are some centers in the world which even continue NAM even up to 9 months. So depending on the case, on an average, if you have chosen an ideal, patient for treatment, usually 4 months, 4.5 months is adequate to do the required correction. But sometimes for a bigger defect, it might take longer. But whatever literature I have read, 9 months is the maximum people have worked on for NAM. So I would say that for me, most of my patients are over within the first 5 months.
Okay, thank you, Professor. That's very insightful answer and very information. And next question, and what age NAM is not longer indicated and why?
Yes. So again, continuing with what I was saying, see, once the baby is, 7 months old, 8 months old, doing NAM at that time, we are unable to do molding. We can only, you know, for a pre-maxilla which is protruded, we can push it down, but that will not, you know, do molding. That is only bone bending. You know, if you will apply pressure on the lips, what will happen? The vomer bone will bend, but it will not get molded. So if I have a baby who is coming to me at 6 months, 7 months, I am usually not choosing it as an ideal candidate for nasoalveolar molding. Unless there is a very severely protruded premaxilla and the surgeon doesn't want to, you know, directly do, you know, lip adhesion, then I would like to just push the premaxilla a little bit back. But for a unilateral, usually I don't do any procedure once the baby is 6 or 7 months old.
Okay, 7 months. Okay, thank you for your answer, Professor. And next question, please, committee. Now, the correct the position of the premaxilla is there an age limit for using PNAM as pre-surgical treatment?
Yes, there is an age limit. Again, it goes back to the earlier question that I would say that if you are a big, you know, you are starting PNAM, I don't want to start a patient who is already post 4.5, 5 months, because the point is that, you know, the rationale of nasoalveolar molding is defeated. See, when you cannot mold the tissue, then if you were to do a lip surgery, the pressure would be similar to what you were doing with your plate. So the effectiveness of the procedure becomes much less if the baby is 4.5 months old. So I would say that there is an age limit. Don't go to a baby who's coming to you for the 5th month or 6th month to start nasoalveolar molding.
Okay, Professor. And the next question is there a recommended pressure reference for nasal stents, and how to make sure the pressure on the nasal stent is not excessive?
This is a very beautiful question, because this is where we can go wrong. See, the pressure, how do you say that the pressure of the nasal stent is adequate? You know, when you put the appliance in the baby's mouth, you tape it and you put the nasal stents in place. If the tissue is blanched, the tissue is becoming white, that is just adequate pressure. Okay. But if you will increase the pressure beyond that, what will happen? The nasal lining is very, very, you know, it's a very delicate lining. Then if you know, when we were small, how we used to play with our friends and our brothers and sisters, we used to put a small piece of hair into the nose to trouble them. You know, the nostril lining is very, very delicate. So if we apply heavy pressure, what will happen? The lining will get ulcerated. So, you know, we will have to discontinue molding for some weeks. And if we discontinue, the advantage what we were getting for the treatment would be lost. So the simple reference is that when the nasal stent is placed, just see that there is mild blanching of the tissue. You know, it's, when you put the stent, it becomes slightly white. If the blanching is there, that shows adequate pressure. But if you will apply heavy pressure, the tissue will get necrosed.
Okay. Thank you, Professor, for the answer. And the next question, please. Is the use of NAM always indicated for pre-surgical cleft?
It is not indicated. See, when you know, we have a lot of smile train centers which are working, there is a concept called burden of care. What do you mean by burden of care is that, you know, if there is only a pre-surgical cleft, you know, it's only the lip and the nose, you can put a nasal elevator if required, but you do not need to do NAM in those cases. Also, where the defect is small, you know, where the major and the minor segments are apart from each other by 5 or 6 millimeters, you do not need to do NAM. You know, that is adequate. The surgical correction will do the same job. So not every case is indicated for NAM. NAM should be done for bigger defects. Imagine, you know, the parent having to come to you multiple times for treatment. So if it is not going to give additional benefit, there is no major reason why you would like to do NAM for small defects or only for the lip nose deformity.
Okay, thank you, Professor, for the very insightful answer. And the next question, please. Quite nice. Okay. The next question, is it better when the baby cry while we taking impression, or just make sure that the baby is awake? Because it is easier for us to know that the baby is breathing when he or she is crying.
Again, it's a very beautiful question. I will tell you something, I'd like to share that the problem happens when you take an infant impression. The problem is that the baby's airway can get blocked. Okay. Now, when the baby is crying, it's a sign of the airway being open. We are worried about the airway not being blocked by our impression material. Okay. So when you make an impression for a cleft baby, you have to ensure that the airway is open. And the best indicator for an open airway is a crying baby. So what I do is, when the parents come, they are very apprehensive. So I tell them that if your baby is crying during the procedure, be happy that everything is going well. Mother is always worried when the baby cries. No parent wants their baby to cry. But I educate them that if your airway is open, that means that the baby is doing well. Another small thing which you can do is lift the cloth of the baby and see the stomach. If there is blueness happening in the stomach, that is a sign that there is hypoxia happening. So, we have to see the first indication, because, baby's airway, if it is blocked, it will react immediately. So you will have to do a CPR and you will have to work out very quickly on those things. So what we do, 3 things we do. We put a pulse oximeter in the finger. What the pulse oximeter tells us, see, all of us now are, because of COVID, we know the value of a pulse oximeter. If the oxygen saturation falls below 90, that is a sign that there is hypoxia happening in the body, right? Also, if the stomach of the baby is turning blue, it's also a sign of hypoxia. And if the baby is not crying or not reacting, that is a cause for some worry. So if my baby is crying, if the pulse oximeter value is high, I'm very happy. And I look at the stomach and there is no bluishness happening there, I am very happy that the impression has gone well.
Okay, thank you, Professor. Continuing this question, how many hours should the infant fasting before doing the impression to prevent vomiting and aspiration maybe?
Yes, I prefer at least 1.5 to 2 hours of no feeding. I tell them that when the impressions I like to do immediately for the baby. Babies want to feed quickly. So I tell them that, the parents, that they don't feed him and come directly. I will make the impression and then I give them into the waiting room to feed the baby. Okay. So the basic thing is that try to keep at least 1.5 to 2 hours of empty stomach, because what will happen if he regurgitates, there is a chance of aspiration, which it becomes life-threatening sometimes.
Yes. Okay. Thank you, Professor, for the answer. And the next question, please. After we applied extraoral strapping, how do we know the maxilla is in the right position after strapping and not forced to excessive? Is there any landmark to avoid a premaxilla position to posterior?
Right. Actually, if you are using the Grayson technique and you are using elastics to pull, to hold your appliance and the taping, the elastic pressure should not be more than 100 grams. You have Dontrix gauge. You have a gauge which can measure. But if you don't have it, very simply, when an elastic is stretched 2.5 times, Just stretch your elastic 2.5 times. Never go beyond it. If you go beyond it, the force is more than 100 grams. The baby's skin is very delicate. So when you are applying the tape and you are applying heavy pressure, what happens? The areas become ulcerated. Once they become ulcerated, again, the problem starts that we will have to remove the appliance for some time for it to recover. So the good time, we have a time window for nasoalveolar molding, 4 months. So if we have lost 2 weeks just for the healing to happen for the ulcer, we have lost a good time for the treatment. So excessive pressure is not a good idea. Even the pressure, if it is slightly less, is okay, but it should not be very excessive so that ulcerations don't happen. So from my perspective, if you are using the Grayson technique, you have to pull the rubber band 2.5 times, not beyond that. And if you exactly want to measure, I would say not more than 100 gram of force. If you are using the Dynaclef taping system, then make sure that the tissues come together as close as possible. When you hold it with your fingers, bring the lip tissues together and then apply the tape. That would be adequate pressure.
Okay. Thank you, Professor, for the answer. And the next question, please. What complication can occur when using NAM?
Yeah, right. See, there are multiple complications which can happen. The major, first complication is while you are making the impression. Like I discussed, you can block the airway, you can have a regurgitation, you might have, hypoxia for the baby. So impression making has to be done properly. Second complication which can happen is, ulceration in the oral cavity, ulceration in the nose, ulcers forming on the, cheek mucosa, on the cheek tissue. Now, we need to understand that why these happen. See, when we give an acrylic plate, we in dentistry, we give acrylic denture to old people. They can tell us where it's hurting. When we ask, we give a denture to somebody, he knows that it's hurting me on the upper right or left side. For a baby, he will not be able to tell us. So what happens that when you are delivering the plate, make sure that all the edges are very, very smooth. Feel it with your thumb and make sure there is no sharp area which is going to hurt and cause intraoral ulceration. Also, when you are applying the nasal stent, don't apply heavy force so that, and also you can add a small reliner on the nasal stent bulb so that it doesn't hurt the nasal tissue. When you're applying pressure on the tapes, make sure that the oral ulcers don't happen. So there are, pressure tapes which can be placed before you apply your tape. Okay. So the major complications are these only. Sometimes what has been reported is that the appliance has gone down and there is a obstruction to the airway. So what you can do is in the Grayson appliance, make a hole in the center, 6 millimeter hole. Now, what is it doing? That if there is an accidental dislodgement of the plate, the baby's airway doesn't get blocked. It's open. Okay. So the major complications are not in terms of, many big losses. The major complications are only ulcerations because of the delicate nature of the skin of the baby and the mucosa of the baby. So you don't want to lose on the working time. So those are the complications, nothing very big.
Okay, I think it's very clear answer, Professor. Thank you. Is there any question from share screen? Oh, for setting a palatal hole on the oral appliance for making airway, I wonder is there any risk of milk aspiration for the baby? Does the benefit of airway outweigh the risk of aspiration?
Actually, it's a very beautiful question. See, this hole, palatal hole, is for the airway. But, when you feed a baby, make sure that the baby is at 45 degrees. The baby is not upright, it's 45 degrees. The feed has to be at an angle so that, the milk is going inside. And if you are, after small feeds, you are burping the baby. If there is accumulation, there is a possibility of a regurgitation. But this small hole doesn't have such a big potential to cause this major loss. So nothing to worry with this small size of the hole. Okay, it will not be a problem. Only thing is that you should know how to feed the baby. And there are a lot of feeding videos available on the Smile Train website also, and there might be in your program how to feed the baby. So that is very critical to understand, because you have to angulate the baby, you have to burp them frequently, so that possibility of aspiration doesn't occur.
Yes, thank you, Professor, for the answer. Next question. Is there any question? How could parents maintain this device? What instructions should we give to parents who have baby with NAM installed?
Very good question. Actually, see, as a clinician, the instructions we give to the patient determine the success of the treatment. Now, the instructions, if I were to give my NAM plate to the baby, the first instruction is the amount of wear, that it should be worn maximum amount of time, 24 hours. Many times what happens that there are parents who come that we make the baby wear it for 10 hours, but we do not, make it 24 hours. Also, the other thing is that the baby initially, when you will give the appliance, will be very uncomfortable. Imagine there is a new thing, so baby wants to pull it out. So what I suggest to them is that their hands are covered with mittens. Those the on the feet we wear, to keep ourselves away from cold. So mittens can be placed on the hand so that the baby is not able to pull the appliance down. Okay, they don't have their fingers and mobility to pull it down. The third instruction I give is to how to keep the appliance clean. Try to understand that in the oral cavity, when the baby's feed is given, there is a possibility of having a candidal infection. So we do not want, with so many fungal growths happening and this thing happening, it is not good, because finally when the palate tissue will be closed, finally when the lip surgery will be done, that tissue, if it is not healthy, will not help in the good repair. So I will tell them to keep the appliance clean. I will tell them not to use abrasives to clean it, because that will make the surface rough. Okay, so first instruction is that the baby is going to cry for 2-3 days. You have to motivate yourself, and in 3 days everything will fall into place. Second instruction is keep the appliance clean. Possibly after every feed, just take out the appliance, wash it with water. The more important instruction is that most people think that they will boil the appliance and it will become sterile because it's going into the baby's mouth, but it's acrylic. So what will happen? It will get distorted. It will not fit it. Also, the soft reliner should not be pulled. The soft reliner, people think that there is something on it, so they clean it and remove it. So, we have to show them. What I do is I make a small video of how to handle it. I teach them how to place the elastics, everything once, and I tell them to click some pictures of their baby with it, so that they are tuned to it. But these instructions, if given well, will ensure the success of treatment. And the most important instruction is 24-hour wear. If we tell them from the beginning that there is no compromise on the number of hours of wear, then only success will come. If we tell them few hours of wear, it will not work out.
Okay, thank you, Professor. It's very insightful answer for this question. And the second question, insert screen. In the remote area, which clean water is difficult to be found, so we cannot do oral hygiene and clean the device thoroughly. Should we use this device PM installed, or we can choose lip tapping only?
See, I will tell you one thing, that even if clean water is not available, we can boil the water and use it for cleaning the appliance. That is not the big issue. The big issue is that, see, the choice of using taping or the NAM appliance are different things. Try to understand, if there is a patient with a cardiovascular anomaly, there is a patient with a respiratory obstruction with a small jaw, micrognathia and Pierre-Robin syndrome. So in those patients, the plate is going to help you. Try to understand that if a patient of Pierre-Robin syndrome is there with a cleft palate, with a large tongue and a small mandible. So what this plate will do is, it will push the tongue down. and open the airway. Okay, so just taping will not help. So what I want to say is that, the choice of whether you want to do only taping or give the NAM appliance should not be the water. The choice should be the anomaly. What defect requires only taping and what defect would require taping with the appliance. So, those factors are different. If water is not clean, better to boil it and keep it for cleaning. But, if you use only taping, I would, deaf children are associated with syndromes. So there, I do not want to add on, making an impression a difficult thing. I would just like to do taping. Many times there are multiple other anomalies happening. So the parents will not be able to do NAM so easily. Malnutrition, baby is small. So multiple other factors what appliance to use.
Okay, thank you, Professor. Is there any question from share screen? There is a question. What are the complications if we use appliance for long term or if a patient doesn't follow hygiene instruction?
Yes, there is a complication. Like I told you, candidal growth happens very easily on these appliances. And if oral candidiosis happens, you have to use candid lotion to apply on that. But you should be vigilant enough. What happens sometimes is that when we only look at the plate and we only look at the nose and the lip coming close. So every time the patient comes, we need to examine intraorally. And I will give you one more tip, that when you make the impression, please examine the oral cavity, because sometimes a fragment of the impression material might remain there and become a source for foreign body reaction. There might be bacterial fungal growth happening there. So, you have to be vigilant at every visit and make sure that hygiene instructions are followed.
Yes, thank you, Professor, for the answer. Is there any question from share screen, the committee?
Yeah, there is one.
I think we already the last question, maybe.
Yeah, you said, is there any consideration to stop using NAM and can continue with the primary surgery? See, many times the patient is uncooperative. Like yesterday only, I had a patient who is 9 months old now. Because of COVID, they came twice. The baby was wearing the appliance only for 5-6 hours a day. Nothing was moving forward. The taping was not done for, they used to do it for 4-5 hours. It was not, reaching any end. So I suggested to them that go for primary surgery, because it's already a 9-month-old baby. Whatever I might do, I will not get a good result at this moment of time. So many times there are considerations where, you will have to go for primary surgery, but I only start patients by educating them. I tell them that do not waste resources. We have limited resources. If your child will follow this protocol of NAM, only then go ahead. Many times the patients are unable to travel. They come from very remote areas where they can't come frequently. So if they cannot come or if they cannot follow the instructions, there is no point in pursuing NAM. They should go for the primary surgery. At least, extraordinarily the child looks well.
Okay. Thank you, Professor, for the clear answer. And the next question, is there any question from share screen?
Doc, I think there is one question from chat. May I read it for you?
Yeah.
Okay. If the baby have allergic in acrylic, what that we usually use for NAM, is there any solution to repair the cleft before surgery?
See, very good question, that there are some people who are allergic to acrylic. In those cases, do not use acrylic plate. You can use aligners. Aligners are made of bioplast material. Bioplast material is, most people, it's a inert material. So that can be used. In fact, recently we had an article which is going to be published very soon. We were the first ones to publish on aligner NAM in the Cleft Palate Craniofacial Journal in 2019. And now the second part comparing Grayson versus aligners. So if the patient is allergic to acrylic, Aligners are the answer, and the advantage of aligners is one. See, you can give 15 aligners to the baby and send him off, and there is no chance of ulceration in the oral cavity because the material is smooth, everything is not hurting the baby, and biostar material doesn't have rough edges if it is polished well. So if the aligner box is given to the baby, and then online you can just discuss with them how the progress of the treatment is happening.
Okay, thank you, Professor, for the answer. I think it's the last question.
Yeah,
Yes,
that's right.
thank you very much, Professor. I will conclude about discussion today. PNAM, not only the reduction of the size of the cleft, but also the active molding and positioning of the surrounding soft and hard tissue affected by the cleft and cartilage in the cleft nose. And PNAM may be successfully employed in the early management of both the unilateral and bilateral cleft anomalies in newborns. Thank you very much, Professor, for the interesting discussion, so we can improve our knowledge about the treatment of infant with cleft lip and palate with pre-surgical nasoalveolar molding or PNAM.
I have just posted my email ID in the chat. If there are other questions and my phone number, anybody has any questions can message me and I will get back to you. Also, we are working on a lot of projects on cleft. If anybody is interested to collaborate, I am always open. We have also a PhD program for cleft also. So anybody interested can be part of it.
Okay, thank you, Professor. Finally, I would like to express our gratitude to Prof. Puneet Batra. We hope to meet you again soon in person someday, maybe, Prof, to share the cases and treatment in infant with cleft lip and palate in prosthodontic specialistic in here. Hopefully this discussion and information about PNAM that we have shared today would be useful for all of us. Thank you, Professor Puneet, and all participants for your great attention. Have a nice day. I give the time to the committee. Thank you.
Okay. Thank you very much, Prof. Puneet Batra, for a very great explanation. And thank you for very kind to us to send your contact. And thank you very much for Dr. Lisda as our moderator. But before that, I would like to take a picture of us. So I will take a screenshot and maybe the participant can open their camera because we're about to take a picture.
And do send me also.
Okay. Okay, Prof. I will send it to you. Okay, the committee can help me with taking a screenshot. Okay, I will count 1, 2, 3. Okay, slide 2. 1, 2, 3. Okay, thank you very much for the committee. It was a great opportunity for all of us hearing the valuable knowledge from Prof. Puneet Batra on this special occasion. In these hard times of the pandemic, we can still find the bright sides. And I believe that this would be an inspiration for all of us to learn cleft lip and palate more and more, even further, to implement the best treatments for our cleft patient. Keep being motivated, pace yourself to learn, and continue completing the courses because we have a lot of amazing speakers coming. My name is Josephina. On behalf of the Faculty of Dentistry, University of Pajajaran, and the entire committee would like to thank Prof. Puneet Batra as our speaker, Dr. Lisda Damayanti as a moderator, and participants who have joined this live discussion. Goodbye and stay healthy, everyone. See you on the next live discussion.
Thank you.
Thank you.
Thank you so much, Prof.